sessions that follow today's. And so we'll hand it over to Deepa.
Thank you, Liz. So as I said, I've already introduced myself. I'm going to be taking you in this journey in a joint learning on vaccine demand. So it's a pleasure to start off this first session on giving you a more of a rounded view of what vaccine demand is and challenges. Of course, we'll be unpacking it throughout the course of the training, but I'll take you through basically a summary of the key highlights. Next slide, please. So when we talk about the state of the global vaccine demand, we start with the problem statement. Basically, what we have seen in the past 2 years is that global efforts continue to bolster the COVID-19 vaccine demand and restore routine immunization. It's important that we focus on routine immunization and transition from COVID-19 vaccine. However, we also know that even before the COVID-19 pandemic, many children were being missed out from routine immunization, which could have saved their lives or which could save lives. COVID-19 has indeed disrupted immunization, leading to an additional cohort of unvaccinated children, exposing them to risk of getting diseases. And majority of these unprotected children are zero dose. By that, what do I mean? The zero dose means that many of them have not had an opportunity of getting vaccinated. One. Next slide. So when we looked at a couple of years data, it shows that in 2020, the global DPT3 immunization coverage really went down to 83%, resulting in almost more than 22 million children under-vaccinated infants and 3.7 million, more than 3.7 million, which we saw in 2019. And when we looked at the measles data, what it showed was that the coverage of the first dose of measles vaccine dropped to 84% in 2020, the lowest level since 2010, and that led to 22.3 million children vulnerable to measles. And as you know, that measles can be quite a dangerous disease for the children. Next slide, please. Now, the interesting thing, and just to keep it in mind, is that over 50% of zero-dose children live in basically more or less 3 settings: remote rural, urban poor, and those areas which are affected by conflict. Pre-pandemic analysis suggests that nearly 50% of vaccine preventable deaths occur in these 3 areas. 2/3 of the zero-dose children live in extremely poor households suffering from multiple deprivation. We might think that immunization is the only problem we are facing, but when you look at these zero-dose communities, you find that there are all kinds of health-related problems as well. The zero-dose children, therefore, becomes a marker.
You have muted the speaker.
Sorry.
You have muted the speaker. Please mute people individually. Sorry, Deepa, could you please restart the slide? Thank you.
I'll repeat. Thanks, Tina. So what I was saying is when we look at the data, more than 50% of zero-dose children live in basically 3 settings: remote rural, urban poor, and those areas which are affected by conflict. Pre-pandemic analysis suggested that 50% of vaccine preventable deaths occur among the zero-dose children. And 2/3 of these zero-dose children live in extremely poor households where there are multiple deprivations. You might be thinking that immunization is the only problem in these zero-dose communities. It's not actually. It's a lot of other things, like health indicators are very poor. Sanitation is really bad. We will see that nutrition in terms of stunting and all is also quite a huge problem. So multiple areas of interventions need to happen there, but these are classically, it gives an indication that zero-dose children are also markers of missed communities, because these communities have been missed for many, many years, and that's where we should be focusing on. And of course, one very important thing to keep in mind is gender-related barriers, both on the demand side as well as supply side, can determine immunization programs' achievements. Next one. So, vaccine hesitancy, as if we saw in the slides and the questions that Liz had shared with us, and we responded to, vaccine hesitancy was mentioned by many, many of you, and rightfully so, because in 2019, WHO declared vaccine hesitancy as one of the top 10 threats of public health. So you can imagine how important it is for us to talk about, and you already know about it. The COVID-19 infodemic is having a negative impact, more than ever. Vaccine hesitancy has been there for quite a while, but it's really increased exponentially since COVID-19 started, and it has eroded the vaccine confidence. It's got a risk that it can erode the vaccine confidence gains that we've made in the past decade or so. Vaccine hesitancy is complex and context specific. So we cannot say that it's going to be the same for every area and every community. And it's influenced by a mix of behavioral determinants. The bedrock of vaccine acceptance is public trust, and whether you trust the vaccine, people trust the vaccines, but also the vaccinators and health services as a whole. Understanding what motivates people's decision to vaccinate then helps to engage with them more, listen to their concerns, and address them. Next one. So just giving you from different kinds of surveys and studies we've done as a global perspective, what are we seeing? What are some of the contextual factors? And these are just a few, and it could be very contextual in some of the countries and communities, as I said. So basically what we've seen since COVID-19 started is that it's been really a high visibility. We are talking about in COVID-19, there's been, the pandemic has been a threat to losing gains on RI. There were multiple uncertainties regarding COVID-19, how we respond, the disease, the new variants, and so on. We've also seen an increase in vaccine hesitancy among health workers. There have been safety concerns, particularly among women. New target populations. We knew how to vaccinate under 5, but this is also, of course, about everybody. So everybody needs to be vaccinated. So it was a huge cohort of people that needed to be vaccinated. In the earlier days, there was a high expectation that everybody would be getting vaccines. Vaccines were not there yet. Equity concerns, and some of you mentioned it in your answers. And infodemic, as Liz said, has been quite a huge thing since COVID-19. And of course, there's always going to be an anti-vaccine activism by some people and some populations. So that's something which we also saw as a contextual factors. Next one, please. And some other complexities in the time of COVID-19. We keep, even now, we keep hearing about it, emergence of new variants of concerns from Delta to now we are talking about Omicron. More children are getting infected with the COVID-19 virus. Initially, we thought that children were not so much affected. There is low risk perception, particularly after the Omicron started, because people think, oh, it's going to be pretty mild, so I don't need to be vaccinated. There are gender issues, women's access to information, mobility issues, because in some parts of the world, they have to take permission from their male members of the house to go and get vaccinated. Registration of vaccines is not easy for many, particularly when we talk about the vulnerable groups and also illiterate groups. So it can be quite complex and daunting for many people. And poverty underpinning decisions to seek care overall. Next. So when we think about what could be some of the intentions and drivers of vaccine uptake, and some of it I already talked about it, but basically this is putting it more in a systematic order. So many people are influenced by how they are thinking about and feeling about vaccination. What is the perceived risk about the COVID-19 as a disease, and what do they think about getting vaccinated? There are social processes. If my community, if my friend doesn't want to get vaccinated, should I get vaccinated? Is it good for me? And is the health worker recommendation, do you trust that? And then, of course, the motivation fact, the intention to get recommended vaccines, even after you've heard about it, you've got the knowledge about it, do you have enough motivation to go for vaccination? And there are lots of practical issues. Some of it I mentioned about whether it's affordable, whether the outreach are there close by. Is the health worker actually a nice person? Do you trust them? Respect from health workers? Do you feel that you get respect from the health workers and vaccinators? and vaccination itself, uptake of recommended vaccine. So all these processes at the end of spectrum, you'll see that all these factors would be leading the decision whether or not to get vaccinated. Next one. So just a snapshot to say that it's very interesting that when a survey question was pulled in many countries, and this is from the RCC collective service that we got the data, that many people, actually more than 90% of people have said that if vaccines were to be available, they are willing to get vaccinated. Next. And when you unpack from a global dashboard, some of the critical barriers that I've already talked about, why do people not go for vaccination? 32 countries said that it is primarily the practical and logistic issue. So you see, when we talk about vaccine hesitancy, it's not just that you cannot put all the blames on communities saying that it's because they didn't want to. There are so many factors which lead people to vaccination. So practical issues like whether it's easy to register, whether the access is easy, affordable. So those things were quoted by 32 countries. 23 countries said that primarily thinking and feeling, what is it that I think about it? Do I believe in it? What do I feel about the perceptions and all? Were the driving force. And then the 7 countries said that it's also the social processes. Let me wait and see what my community, what others are going to do, and then I'll follow suit. So these are some of the things that the data is telling us. Next. So in a very short summary of what really needs to be done as we move forward, and as I said, these will be unpacked as we go through a lot of sessions that are being lined up for you. Focusing on zero-dose communities and under-vaccinated areas is a must. That's the call of the day. I think many countries have reached about 80 or 80% of the vaccination, but some countries lagging behind, some countries are doing better than, but more or less 80% plus, as we saw in the DPT1 coverage and measles coverage. So now is the time we really need to focus on children who've missed out and have been under-vaccinated, meaning that they might have got 1 or 2 vaccination, but may not have completed the full course. One important thing as communication people, as demand promotion people, it's almost like our mantra, Bible, or whatever you want to say, is listen to the communities, listen to what people are saying. What are the fears? What are the concerns? Why are they not really up to going for the vaccination sites and getting children and adults vaccinated? So social listening becomes very important for us. Let's analyze it. Let's hear from, we're not talking just about social media. We're talking about different platforms which will allow us to listen to what people are saying. Let's analyze the data and use the data to inform our strategies. Building in-country capacity on demand promotion, engaging with communities from the beginning, not just when we need to actually have their support for vaccination, but making them a part and parcel of everything that we do, because we put communities at the center, as Tina said when she was talking about human-centered design. Co-creating and co-engaging with them. When we find out that these are the real problems, let's sit down with them and ask them what would work for that particular community and what we need to do. Promoting pro-equity, gender-sensitive, evidence-based, tailored strategies. A generic strategy is not really going to work when we are trying to reach the last mile. So let's think of what could be some of the tailored strategies we need to do based on data. Making vaccination easy, convenient, and integrating it into primary healthcare package. More and more the communities are asking, we want to have an integrated package. So what is it that we can integrate, not just on the communication front, but also on the service delivery? Working with health workers to improve the service experience, and also integrated approach to demand promotion, immunization plus and other services, which would be more palatable to many communities. Next one. So just as a country example from Indonesia, which is a big country with a big population. So this is just to give you a flavor of what countries have been doing and what can be done. So the issue was misinformation and rumors on social media threatening uptake of COVID-19 vaccine. A nationwide survey was conducted in 2020, which found that 64 and 79% of respondents was susceptible to disinformation online. So between 64 to 79 people said that they are susceptible to getting information and misinformation mainly. An overwhelming majority said they primarily seek information through social media and share with others. So the risk is quite high. Risk of people believing fake news or hoaxes, especially religious and political, making it difficult to change their mind. So it was quite this is basically the situation that we found in the 2020 survey that was done in Indonesia. Next. So what did the Indonesia team do then? When a national emergency was declared in March 2020, UNICEF with CDC and Ministry of Health and partners, they got together and supported the ministry to develop a website which people could go to for accurate information. We worked with a local organization, Mafindo, which does fantastic work in Indonesia, to create Hope Busters section that had produced over 870 articles evaluating online content related to COVID-19. So the inoculation project too, and Liz is here, she was instrumental in making this happen and supporting the Indonesia country team. Was implemented to provide accurate information and build digital literacy as preemptive approach in elderly population via trusted community workers. And please do keep in mind, colleagues, that one thing to be mentioned is that among the priority population, reaching the elderly population has not been that easy because, we need to find out what are the methods that we can really reach them, who are the influencers, how can we really make an effort to reach the elderly, because it's not that easy to reach them. Next. So after what was done and the massive effort on communication and behavior change, the messaging and community engagement, mobilizing the influencers, the result was that it did increase awareness about misinformation techniques to address misinformation and protect people against future hoaxes. Capacity building was done of 92,000 vaccinators on how to use these techniques. And a survey which was conducted between March and April last year, 2021, found that vaccine acceptance among Indonesians had increased from 20% since the end of 2020. So it does work, but we do need data as demand promotion people, as people who work on SPC, because data is a powerful tool to advocate for, not just for making people believe in what you are saying, but also to ask for resources and support from the governments and partners. More than half now say that they are willing to get vaccinated. I think it was quite a big win for the country. Next. So this is another example. No, if you can just go back to South Sudan, the previous one, please. Yeah. So in South Sudan, this is very specific to gender issues. So what was done using the behavioral and social drivers tool that has been developed by the Demand Hub, the work stream which is working on the BEST. So a survey was done among females to understand why is it that the uptake of vaccine is lower among females compared to males. Then, based on what the data found out, demand strategy was subsequently revised to put more emphasis on women-centric approaches, having influencers reach women, community engagement, targeted approach to reach them. Interviews of influential women, including the Undersecretary of MOH, the Ministry of Health and Ministry of Gender getting vaccinated, really had a positive impact. Communication materials subsequently were also developed focusing on women, and you can see that in one of the pictures there. Specific concerns of women around vaccine safety were addressed. The social listening and the data gathering has been quite strong in South Sudan. And all these interventions did indeed contribute to an increase of 40% of vaccination among females. Next. So there have been a lot of challenges, as you can imagine, and we still continue to face these. Competing health systems priorities and overstretched health systems, because there's been so much effort to make sure that everybody gets an opportunity to get vaccinated. The workforce has been stressed thin, as you can imagine. And so it means that they are juggling with the COVID-19 vaccine as well as the routine providing other essential health services. There has been interruption of routine immunization after the pandemic, and it has contributed to leaving many children unvaccinated or under-vaccinated, as I said in the beginning. We are seeing other disease outbreaks which require attention. Changing and evolving situation of COVID-19 virus continues to be a challenge for many of us. Epidemiological surveillance systems have been weakened during the pandemic, making it difficult to detect and respond to new outbreaks, leaving children and communities vulnerable to many diseases. Next. So what are the opportunities? Everything is not so gloomy. So I think every emergency does give us some learning, some things that we can reflect on and think, how can we make it into an opportunity? So there has been a lot of efforts put by all governments all around the world together with support of the partners to build the systems, because it's at the end of the day, it's the health system. If it's robust, then it's likely that they can respond to the needs of the people. So systems strengthened for COVID-19 can be leveraged for promoting routine immunization and new vaccine introduction. For example, more than 90 plus countries have already got some kind of a social listening mechanism. We are gathering social data. We've got a mechanism to analyze and build capacity and use the data for informing our strategy. So this can, of course, be used moving forward for routine immunization. Capacity building of frontline workers and interpersonal communication will also benefit the routine immunization and broader primary health care. Some of the things like the efforts in human-centered design, how do we use it as an approach to work more closely with community engagement, can also benefit the primary health care. Partnerships established for COVID-19 can indeed be leveraged for other areas as well. We've been having really good partnerships, like, for example, with the faith-based actors, with academia, and also private sectors. Facebook, for example, Facebook has been doing really a lot of surveys across many countries. So these partnerships can be leveraged to benefit the routine immunization later on as well. And one big thing which is being talked about, and it's very important, is how do we integrate the learning that we've got from COVID-19 into routine immunization? And there's an opportunity to strengthen the preparedness and response for future pandemic, because who knows when is going to be the next pandemic. We've seen the pandemics in the past with the H1N1 virus. We've seen Ebola, which some of the learnings have been used to COVID-19. And of course, the COVID-19 learning can also help us strengthen the resilience of the systems, but also communities. Next. So how does it all come together? As Smita mentioned in the beginning, the Demand Hub is a partnership, a collective coordination mechanism where all the partners working at global level, but also at the regional level, have come together. And this was established in 2018, and it's been going quite strong. The partnership is quite strong, and we've got different work streams under the Demand Hub. So what this training is going to align with is what we have been trying to do with the Demand Hub. So we will be focusing on the digital. There are digital work stream in the Demand Hub. There is a behavioral and social drivers work stream. We've got behavioral interventions, the service delivery, and also civil society engagement. So you will see throughout the training that a lot of these things have been actually organized according to these different work streams that we are trying to strengthen, because that's what is needed when we talk about the comprehensive training. And of course, we will keep on adding, and as we learn more from the participants, but also from different learnings that we've got from across the world. Next. So with that, as I think Smita already mentioned, a lot of introductory videos that you saw mentioned that, through the Demand Hub, we are so happy that we are able to bring this comprehensive training forward, and you will see some of the partners. So I'll just like to end by saying that this is about achieving results together, and this is about global partnership that will support our efforts to strengthen immunization for all people everywhere, every child and every adult. I think that's the last slide. And thank you so much for making the time and joining us for this wonderful comprehensive training. Today is the start, but I do hope that you'll learn and have lots of fun as well. Over to you.